Comprehensive Guide to Anterior Cruciate Ligament Tear. The video is created by Dr. Abhinav Gupta and team. In this video, we have covered everything about the topic from initiation to the end. An anterior cruciate ligament, ACL, tear refers to the damage or rupture of the ACL, a crucial ligament in the knee that helps stabilize and control its movement. The most common mechanism for an anterior cruciate ligament, ACL, tear involves a sudden and forceful twisting or hyperextension of the knee. This can happen during 1. Non-contact injuries. Abrupt changes in direction, pivoting, or sudden stops can stress the ACL. 2. Direct impact. A blow to the side of the knee, especially when the foot is planted, can lead to ACL injury. 3. Hyperextension, excessive backward bending of the knee, beyond its normal range. These mechanisms often occur during sports activities that involve quick, dynamic movements. The ACL, being a key stabilizing ligament, is vulnerable to such forces, and injury can occur. Clinical features. 1. Pain. Immediate pain at the time of injury, often followed by persistent discomfort. 2. Swelling. Rapid swelling within a few hours of the injury due to bleeding into the joint. 3. Instability. A sense of the knee, giving way, or feeling unstable, particularly during weight-bearing activities. 4. Limited range of motion, difficulty fully extending or bending the knee. 5. Popping sound. Some people report hearing or feeling a popping sensation at the time of injury. 6. Difficulty walking. A noticeable limp or difficulty putting weight on the affected leg. Diagnosis typically involves a physical examination, imaging studies, and may require consultation with a specialist. Diagnosis. 1. Imaging studies. X-rays are usually done to rule out fractures, and MRI can provide detailed images of soft tissues, helping to confirm the ACL tear and assess its severity. 2. Two common clinical tests used to assess the integrity of the anterior cruciate ligament, ACL, are the Lachman test and the pivot shift test. A. Lachman test. Procedure. The patient lies on their back with the knee flexed to about 20 to 30 degrees. The examiner stabilizes the thigh with one hand while applying forward pressure to the shin with the other. Positive finding. Increased forward movement compared to the unaffected knee. B. Pivot shift test. Procedure. The patient lies on their back with the examiner flexing the patient's hip and knee. The examiner then applies a valgus, inward, and rotational force to the knee while extending it. Positive finding. If there is a noticeable shift or a clunk, as the knee is brought into extension. Physiotherapy assessment includes 1. History taking. Detailed information on the mechanism of injury, onset of symptoms, and any previous knee issues or surgeries. 2. Pain assessment. Evaluation of pain intensity and location, especially during specific movements or activities. 3. Range of motion, ROM, assessment. Measurement of knee joint flexibility, assessing any limitations or asymmetries. 4. Muscle strength testing. Evaluation of muscle strength, with a focus on the quadriceps, hamstrings, and muscles around the hip. 5. Ligament integrity tests. Performance of clinical tests like the Lachman test and pivot shift test to assess the stability of the ACL. 6. Swelling and joint effusion assessment. Examination for signs of swelling, warmth, and joint effusion around the knee. 7. Functional movement assessment. Observation and analysis of functional movements, including walking, squatting, and hopping. 8. Balance and proprioception testing. Assessment of balance and proprioception to identify deficits that may contribute to instability. 9. Neuromuscular control assessment. Evaluation of neuromuscular control during dynamic activities to identify movement patterns that might increase the risk of re-injury. 10. Patient-specific functional assessment. Consideration of the patient's specific goals and functional demands to tailor the rehabilitation program accordingly. Treatment. Conservative management for an anterior cruciate ligament, ACL, tear may be considered, especially for individuals with less active lifestyles, partial tears, or specific medical conditions. 1. Physiotherapy. 2. Bracing. The use of a knee brace to provide support and stability. The type of brace and duration of use will depend on the severity of the tear and individual needs. 3. Activity modification. Temporarily modifying or avoiding activities that may stress the knee, especially those involving sudden stops, pivoting, or jumping. 4. Pain management. Medications, such as nonsteroidal anti-inflammatory drugs, NSAIDs, to manage pain and reduce inflammation. 5. Protection and rest. Initially protecting the knee to avoid further injury, followed by a gradual return to weight-bearing activities as tolerated. Adequate rest to allow the ligament to heal. 6. Functional rehabilitation. Focusing on functional rehabilitation exercises to improve proprioception, balance, and coordination. 7. Education. Patient education on the nature of the injury, expected outcomes with conservative management, and the importance of adherence to the rehabilitation program. Surgical interventions. Surgical intervention for an anterior cruciate ligament, ACL, tear often involves a procedure called ACL reconstruction. 1. Preoperative evaluation. The surgeon assesses the patient's overall health, reviews medical history, and may order preoperative tests. 2. Anesthesia. ACL reconstruction is commonly performed under general anesthesia, ensuring the patient is asleep and pain-free during the surgery. 3. Graft selection. The surgeon chooses a graft source for the ACL reconstruction. Common graft options include using the patient's own tissue, autograft, often from the patellar tendon or hamstring tendons, or using donor tissue, allograft. 4. Arthroscopy. The surgeon makes small incisions and inserts an arthroscope, a small camera, into the knee joint to visualize the structures. 5. ACL removal. If the ACL is torn, the damaged ligament is removed to prepare for the reconstruction. 6. Graft placement. The selected graft is prepared and inserted into the knee joint to reconstruct the ACL. The graft is secured in place using screws or other fixation devices. 7. Rehabilitation protocol. Post-surgery often involving a structured physiotherapy program. The aim is to restore strength, range of motion, and stability in the knee. 8. Follow-up care. Regular follow-up appointments with the surgeon and physical therapist are scheduled to monitor progress and make adjustments to the rehabilitation plan. Physiotherapy management. Rehabilitation for an anterior cruciate ligament, ACL, tear is typically a gradual process, progressing through different phases. Keep in mind that the specifics can vary based on the individual's condition and the advice of healthcare professionals. Here's a general outline of day-wise rehabilitation, post-surgery. Day 1 to 7, immediate post-op. Pain management. Control pain and swelling through prescribed medications and ice. Rest and elevation. Elevate the leg when resting to minimize swelling. Range of motion, ROM, exercises, gentle ankle pumps and knee flexion, extension within the allowed range. Week 2 to 4. Passive range of motion. Begin passive ROM exercises, assisted by a therapist if needed. Weight-bearing activities. Gradual progression to partial weight-bearing as guided by the surgeon. Isometric quadriceps contractions. Gentle isometric exercises for muscle activation. Week 4 to 6. Active range of motion. Initiate active ROM exercises. Strengthening exercises. Focus on quadriceps, hamstrings, and calf muscles. Balance and proprioception training. Start incorporating balance exercises. Week 6 to 12. Functional activities. Introduce more complex movements and activities. Closed chain exercises. Progress to closed chain exercises to enhance joint stability. Cardiovascular training. Begin low-impact cardiovascular exercises, e.g., stationary bike. Month 3 to 6. Strength training. Gradually increase resistance in strength exercises. Sport-specific training. Tailor exercises to mimic movements in specific sports. Running progression. Start controlled running drills. Month 6 and beyond. Return to sport activities. Gradual return to sport-specific activities. Advance agility training. Incorporate more dynamic and challenging agility exercises. Monitoring and maintenance. Regular assessments and adjustments to the exercise program. Vote of thanks. Thank you for watching our video. We hope this information has been valuable to you. If you have any further questions or concerns, please consult our team for personalized advice.